Hereby, I open this academic ceremony in which Debraj Shome will defend his academic thesis titled Emerging Trends in Facial Aesthetics, Scar Treatments and Hair Growth in India. My name is Harry Schout. I'm emeritus hoogleraar, professor in hematology at this university and pro-rector today. Welcome. May I invite you to give a presentation of your observations and your thesis?
Thank you. Good afternoon, Pro-Rector, highly esteemed members, opponents. Thank you for having me here. I will be presenting my thesis on emerging trends in facial aesthetics, scar treatments, and hair growth in India. My name is Dr. Debraj Shome. And the background and the need is of this type. Essentially, in India, things have become better financially. And India is the fastest growing economy over the past 6 quarters or so in the world at about 8% every quarter. And what has happened is with this exponential growth in financial stability has come an exponential growth also in demand for facial aesthetic procedures. People want to look better, and obviously they're willing to pay for it. The psychosocial impact of this is that there are people who've been impacted by alopecia, have been impacted with the way they look. But these self-esteem issues, this quality of life analysis can now be addressed can be addressed better financially, and that's also one of the things which we are seeing. There are certain population-specific challenges. India is home to 1.5 billion people, which means that 1 out of every 3 or 4 on this planet are Indians. And the thing to understand is that India is actually like a continent. It's almost like Europe. There are 30 languages, there are 800 dialects, and their skin type has varied from type 1 skin to type 6 skin. So all of this means that we need to have specialized treatment protocols and safety considerations for hyperpigmentation risk. And obviously, as it's a developing country, there might not be enough evidence-based, population-specific clinical protocols which we need to develop. That's where my thesis comes in. And my research work is about systematically evaluating and documenting emerging trends in facial aesthetic procedures, advanced scar management protocols, and hair regrowth therapies within Indian populations. So this thesis is divided into 3 parts. The first one deals with facial aesthetics. The second one deals with advanced facial scar treatments. And the third one deals with the clinical efficacy of non-surgical formulations, including the QR678, which have now been patented as well as commercialized in 10+ countries in the world. So facial aesthetics in India, we used, for the scope of our analysis, non-surgical as well as surgical procedures. And we used this particular analysis right from PubMed, Cochrane, Embase, and Google Scholar. Our first paper was about evolution and trends of facial plastic surgery and facial aesthetic procedures in India. And essentially, the 20 relevant studies which were identified from 703 studies that we initially looked at covered major non-surgical procedures as well as surgical procedures. And the key findings were that there is a steady growth in facial plastic surgery procedures across India. And there's a clear shift towards non-surgical procedures, which is very different from the United States where I trained, and also probably Europe, because here people may want to undergo more surgery, but in India, people are not that risk-taking yet. There's also a future direction where we propose strategies to strengthen and standardize protocols in aesthetics practice. These were some of the key findings, with botulinum toxins and fillers being the most common non-surgical procedures, and a facelift, neck lift, and a brow lift being the most common surgical procedures. Our second paper was on the determinants of the influence and experiences of cosmetic and aesthetics profiling on interpersonal relationships, which I found fascinating as I worked on it. And this is a groundbreaking study. Why do I call it groundbreaking? Because 27-item structured questionnaire was given to people who had already had procedures. And what we discovered was that how you looked not only impacted how you felt about yourself, but it also improved the relationships with family and peers post-treatment. So how you look is not really frivolous. It can also impact your relationship with society. These were some of the key findings, and these are the procedures which people had undergone before this questionnaire was administered to them. So the key findings of part 1 was that there's a transformation of the aesthetic landscape in India, which I've already spoken about. And we identified certain critical gaps in regulatory frameworks, training protocols, and also cost accessibility and how this could all be addressed in a preferred practice manner and with evidence-based medicine in India. Moving on to part 2, we spoke about facial scar management. Now, scars, I come from a background where many years ago when I trained, the person who closed the skin wound was usually the youngest in the surgical team. Today, we remember that the only thing that the patient might perhaps see is the scar which is on his skin. And it's not frivolous to be creating scars anymore. So scar management becomes very important. We need to give it the due respect that it deserves. And we did that using certain new protocols. So this particular paper, which was published in Plastic and Reconstructive Surgery, which is the flagship journal of the American Society of Plastic Surgeons, and was also voted as the best and the most cited paper from South Asia in 2020. This particular paper speaks about how we use preoperative botulinum toxin to reduce muscle tension. So essentially what happens is when the muscles act, they tend to cause distraction of the scar, so the scar tends to widen. And if you put Botox around, botulinum toxin around it, it prevents those muscles from working in the first 3 months or so, allowing the scar then to become linear and much more narrower. And after we did the botulinum toxin, then we did the scar revision surgery, which could be flaps, which could be a rotation flap, which could be a W-plasty, which could be whatever, with the application of Centinella cream, which was used for the first time to evaluate if that made the scar any better in the initial preoperative period, and the use of fractional CO2 laser treatment as well. Now, please I would like to bring it to everyone's notice that we come from a pigmented race, and carbon dioxide laser has traditionally been known to cause post-inflammatory hyperpigmentation in Indian skin. But the use of fractional CO2 laser for optimal healing is what was used in this, and this led to some pretty good results, as you can see from some of these patients who've had various types of scar revision surgery done. Paper number 2 was on the efficacy of combination approach using subcision fillers and fractional CO2 laser for acne scars. Acne can be deeply debilitating, and especially in a generation where it causes the reflection of light not to be uniform, it can also cause significant self-esteem issues. Because ice pick scars are attached to the basement membrane below, using subcision to break the connection with the scar with the basement membrane below, and then utilizing fillers to make sure that the scar then comes up to the same level, and thereby allows the CO2 laser to be focused on all elements of the scar and not miss the sides of the ice pick. This is what we suggested. And this showed very good results, and this was also published in a top journal, which is Journal of Cosmetic Dermatology from the United States. And the scar treatment outcomes we suggested actually led to reduced scar widening, enhanced the scar quality, and these were validated protocols in pigmented skin, which I've spoken about. Moving on to part 3 of my work, we concentrated on hair regrowth studies. And there used to be a time, and there is still a time in parts of the world where hair is thought to be frivolous. But honestly, hair can make all the difference in how we look. Think from the perspective of a lady who's had breast cancer. When we go ahead and treat her breast cancer, but we don't treat the hair fall which has occurred from the chemotherapy, and she looks into the mirror every day and recognizes herself as having no hair, does this holistically lead to actually her feeling empowered? Those are some of the questions that we asked ourselves as we embarked on various products to develop hair regrowth. Now, the first thing that we did, this is a patented product, and we do have a conflict of interest. We applied for a patent, got a patent from the United States Patent and Trademark Office, and we commercialized this product. The first thing that we wanted to do with the QR678 was to see how it did against PRP. Platelet-rich plasma was supposed to be the gold standard of treatment at that point in time. What it meant was that you had to take your own blood. There was platelet-derived growth factor in your blood, which caused hair growth. But clearly, earlier studies had shown that there were also some inhibitory factors which were available in blood. And so from that perspective, why in the world, when people are going to Mars on holiday, would we ever want a situation where we need to take someone's blood out in the 21st century to produce growth factors? That's the reason that the QR678 comes in. It has growth factors which are in a vial. It's a patented formulation. And when we tested it in a split, in 2-group study, we found that in 50 male patients, the QR678 demonstrated 3x the amount of hair density and thickness compared to PRP. These are some of the results which came out of that particular study. leading us to start a multicentric open-label trial, which was performed by dermatologists and plastic surgeons, including myself, in various parts of the world. And when we performed this particular trial in South Africa, in Kuwait, in India, in places like Malaysia, we discovered that the QR678 demonstrated marked improvement in hair density, multi-ethnicity. These are some of the results which came out of the same. We also showed that QR678 works very well for alopecia areata. In this immunologically mediated disorder, the QR678 actually primes the immune cells and can work really well. The amount of corticosteroids needed for alopecia areata was reduced in all the patients, and some of them did not need the corticosteroids at all. We also demonstrated that this was the time of COVID, and many of the patients in the countries where the QR678 is approved for usage were not able to come to the clinic. And that's when we demonstrated that intradermal injection therapy, which means using a derma roller at home, provided the same results as an intradermal injection therapy. And that's what this showed could be done even at home. It didn't necessarily need coming into the clinic. These are some of the results which came out from that. Another type of hair loss, which is very serious and severe, is the female pattern alopecia, which is seen in women with polycystic ovarian syndrome. And in these women, the QR678 also demonstrated very good results, as it did in patients who have persistent chemotherapy-induced alopecia due to cytotoxic chemotherapy. And in people who've had various types of cancer, this can actually reinvigorate the hair, convert the telogen and the catagen phase into anagen phase, and lead to hair regrowth. So the key clinical outcomes of part 3 were that significant hair regrowth could be caused, significant clinical evidence was driven, intellectual property was derived from these studies, and there was a superior comparative efficacy as well as a favorable safety profile in comparison to the current treatment protocols which are available. So all in all, my particular thesis talks about novelty and translational contribution, facial aesthetics, scar algorithms which have changed lives, and a multi-indication hair regrowth formulation which has been commercialized as well. In conclusion, I speak about evidence-based evolution. As doctors, it is very important for us to rely on evidence and nothing else. And therefore, the aesthetic medicine in India, as it advances, we need to use validated protocols for all of these problems in the Indian population and use what shows evidence and has a base in terms of the work that we do. The clinical validation has been achieved, and the future research priorities obviously involves collaboration with multicentric trials, investigation of regenerative and molecular therapies. We would love to get into personalized medicine where we are able to treat problems in each person as they develop, and training protocols. My key take-to-clinic takeaways, if I had any, was there is a psychosocial impact of aesthetic interventions. We need to understand that. We cannot take this as a frivolous thing, people wanting to look better or people wanting to not have scars. People want that. It's our job as doctors to provide that and do it in a scientific manner. Advanced scar revision can be performed in darker skin phototypes. When I started using the carbon dioxide laser in India, people were really worried and petrified about the post-inflammatory hyperpigmentation. But if you use the correct fluences, you can get good results. There's been a paradigm shift in non-surgical hair restoration. I do feel that at 2050, any child born post-2050 will not necessarily be bald in his lifetime if he takes treatments at the right period of time. And there are population-specific blepharoplasty techniques, rhinoplastic techniques. There are stratified approaches to liquid or non-surgical facelifts that we have seen. And there is a global impact of the Indian aesthetic innovations, which promises to transform the global spectrum of aesthetic medicine through evidence-based, population-appropriate interventions. Thank you once again for having me here, and I'm very grateful for my opportunity to present my work to you.
Thank you for your clear presentation. The opposition will be opened by Professor Piatkovsky, Professor of Plastic Surgery at this university.
Thank you, Director. Dear promovendus, thank you very much. And first of all, I want to congratulate you for all the hard work that you did, especially to make this research happen next to your daily practice. This can be really hard, and this is really something that should be mentioned. So, but I would like to start by asking a couple of questions, especially concerning Chapter 4. You're writing that you have performed a trial that involved treating patients with a regimen of using Botox preoperatively, meticulous wound closure, and afterwards antiseptic ointments and steroid creams. And on top of that, you also use cicatrix cream in order to get the best outcome. So for me, when I look at this, it seems like evaluating the effect of a cocktail, and it's the same as evaluating if drinking a Long Island iced tea really makes you drunk. Which part of the Long Island iced tea makes you drunk? So for me, this is really difficult then to draw a conclusion, because which part of all your cocktail gets you there where you want?
Thank you for your question, highly esteemed opponent. And you're absolutely right. Anytime that we compare anything, it should be with comparables, and we should be comparing only one thing versus the other. The fact, though, is we deal with patients, and patients may not be willing to be used as guinea pigs. So when we've had earlier studies which have demonstrated the impact of Centinella asiatica, the earlier studies which have demonstrated that carbon dioxide laser on Indian skin can reduce the visibility of scars, earlier papers which shows that movement post-botulinum toxin because of the paralysis of the adjacent muscles will reduce, then it would be fair to hypothesize perhaps that if we use botulinum toxin and prevented the movement of the skin, that would cause the scars to become more linear, and then use a number of techniques which could be used to make it better. I completely understand no one study will be able to have all the answers, and I completely understand that there is a concern with regards to multiple modalities being used in these patients. However, what has interestingly happened is, by virtue of us using botulinum toxin in order to paralyze the muscles prior to the surgery, I'm also told that there have been certain thoughts that companies have had of applying this and applying to the FDAs around the world for approval as a specific type of indication for botulinum toxin. So this is a preliminary and an initial study, and I completely, absolutely respect what you've said.
Thank you.
Thank you so much.
But you've touched there on a point that is also concerning me a little bit, because you're assessing your result, but what do you compare it with? Because in this study, you do not have another group that you could compare it to, or do you?
So we took photographs of the patients who were being treated, and some of the photographs which I showed actually showed a significant improvement in the pre and the post-operative results. And what we also did is we took very wide scars. So when you take wide scars, if the scar tissue is very wide, just using something like a carbon dioxide laser on top is not going to reduce the width of the scar. It can change the way the scar ends up looking, but may not necessarily reduce the width of the scar. So the combination was chosen in a manner which allowed us to get the normal skin on the sides of the scar tissue together, prevent it from meeting, prevent it from, being pulled apart by the action of the muscles, especially in parts of the face where the facial mimetic muscles are continuously moving, and therefore lead to better results. So the pre and the post pictures, which were taken at some time to each other, demonstrated better results. Also, a structured questionnaire was administered to the patients themselves, who spoke about how it became better.
But normally, you would have a control group where you would compare it to.
Absolutely.
Okay. If we find this ground, then I'm fine. And what also really triggered me was that you just chose cicatrix cream, which is, of course, a commercial product which is known for a long time. But we have here in Maastricht also a specialized scar clinic, and there has also been done some research on it. And and cicatrix and all these scar creams do not come out as really something that we recommend here, because there's not a lot of evidence for it. What is really evidence for is scar creams based on silicone, and what is even better are silicone sheets for scars. Would you use them maybe in a future research?
Highly esteemed opponent, we've used them right from the beginning over the last 15 years or so. And there was data on file available prior to this particular paper being published and worked on, which showed that contract tubex or silicone sheets as well as gels, and when we compared them with psychiatrics, there was reason to believe that psychiatrics was having a better impact, especially with regards to reducing the amount of pigmentation in the scar tissue, which is a big problem with pigmented races having skin types 4 to 6. So from that perspective, when we started seeing those results and the data on file was available, we decided to use this as part of the scar treatment to see what ends up happening. Also, silicone sheets, while they do a great job of flattening highly raised scars, they may not do too much in terms of improving the visibility or the way flat or depressed scars look. So from that perspective, basis what we had as initial knowledge, that is what was transported as a hypothesis and then tested in this particular paper.
Okay, then maybe you should publish this. Thank you. I'm going to give the word back to the pro-rector.
Thank you. The opposition will be continued by Professor van der Leij, Emeritus Professor of Plastic Surgery at the University of Groningen. Thank you for joining from far away.
Yes, thank you. Being able to discuss with you. First of all, I would like to congratulate the candidate with this work. And I also would like to express my congratulations to your supervisors, Professor van der Hulst and Dr. Bowen. But first of all, I would like to go to chapter 3, which is very interesting. Although I'm not a psychologist, I have worked a lot with them together, and I love what you've studied there. As we all know, as medical doctors who do aesthetic treatments, we actually work on the cutting edge of the body and mind. We do some treatment and it has a significant psychological effect. And you studied an interesting aspect, especially that aesthetic treatments on patients improve the relation with the social environment. My first question is, how does this work? What is your explanation for it? So I want to go a bit deeper than just a conclusion. What's your idea about this aspect?
Highly esteemed opponent, thank you so much for your question and thank you for joining us online. I think the world flows through our own relationship with one own self. I think it's very difficult to be happy with the world when you're not happy with yourself. If you have a good relationship, a satisfying relationship with your own self, you can have a satisfying relationship with others because it's your comfort. So it's like this. I always speak about this, that whenever we are being spoken about, suppose someone looks at me and says that I'm looking good, and I believe I am looking good, then I might take that as a compliment. On the other hand, if I don't believe I'm looking good, doesn't matter what the person in front tells me, I might take it as sarcasm on the part of the other person. So from that perspective, our own relationships with ourselves play a major way in the way we interact with the world. And I think what is on the head, which is hair, or what is on the skin, which are scars, actually start impacting confidence inside the brain. And from that perspective, that makes all the difference in the way we relate to people. We've had patients, I would like to talk about one particular patient. We've had patients who've actually never disclosed. I had this very interesting patient who'd never disclosed to his wife of a couple of years that he was bald. I don't know how he managed to do it, but he was wearing a wig. And one day, that wig, in a moment of intimacy, came off in the wife's hand. And ultimately, that led to a situation where there was a relationship breakdown between the two people because it was all about confidence in each other, and it was also about comfort in each other's ability to speak the truth. So I think interpersonal relationships are impacted by the way we look because it impacts the fundamental confidence that we have in our own capabilities and the picture that we present to the world. And in that sense, our partners are merely mirrors of what we think about ourselves.
Okay, thank you. I agree with you. You also found a difference between men and women in regard of this aspect. How do you explain it, that there is a difference in, let's say, our confidence and social success to facial beauty between men and women?
What
Why
we've
is
seen,
facial beauty more important for women than for men, for example?
highly esteemed opponent, thank you for your question. And that seems to be changing now. At least in our practice now, which has been over the past 15 to 20 years, we see many more men coming in for facial plastic surgery, facial aesthetics treatment as opposed to earlier. Earlier, when I started off my practice, at that moment in time, women were about 80% of our patients. Today, it's almost 50-50. In some places, in some of our centers, there are more men coming in than there are women coming in. I think these changes amongst the genders have got neutralized by the important factor that social media has played on both types of minds. What we've realized is that everyone would like to present their best foot forward. And if everyone's going to put their best foot forward evolutionally, there's no reason really that our baggage, that men respond to beauty or respond to their looks in a different manner compared to women, needs to be necessarily carried through into the 22nd century as well. So I do see more and more men being concerned about how they look, taking, whether it's longevity protocols like working out, making sure we are fit, or taking treatments. I do see many more men relating with that. And therefore, my understanding is that in the future, there will be many more men who will undergo treatment, and it will impact their relationships with their spouses as well, not necessarily only of the women with the men, but also of the men with the women.
Okay, thank you. Now I would little bit discussion about your way how to treat scars. You have chapter 4 and chapter 5, two different strategies. It's of course very difficult to see what is what is what. But when you look at chapter 5, you use a filler to correct a depressed scar and then have an even distribution of the scar so you can do the laser treatment. But why not using additional Botox in this situation? Because that seems to relax the muscle. So I wonder why you didn't include in chapter, let's say in your therapy in chapter 5, why you didn't add Botox, or was it just, is that the next experiment?
Highly esteemed opponent, thank you so much. Chapter 4 and chapter 5 are very different from each other. Chapter 4 has scars which are caused by, let's say, trauma, whereas chapter 5 has scars which are caused by acne. Acne scars, especially in highly pigmented skin like ours, leads to ice pick scars. What that means is the scars become very narrow. The scars have a wide base, but they have a very narrow apex. And what happens because of this is that there is a lot of scar tissue which tends to attach the skin to the basement membrane below. Now, this scar is very different from a wide scar. Because the scar is narrow and pointed like a V, essentially when we try to use carbon dioxide laser, the laser beam would never be hitting the sides of the scar which are deep into the pocket. It's like a pothole on the skin. So from that perspective, using subcision, first, a needle, a 26-gauge needle, which goes below the scar in order to break the adhesion of the scar with the underlying basement membrane, would allow the scar then to come up and be released from the basement membrane. What seemed obvious to us was that unless and until you release the adhesion to the basement membrane, how do you even get the scar to get treated, and how would laser make a difference? So once you've done that, you've actually separated the scar from the basement membrane, but the tissue below is raw. If there is any raw tissue, we as plastic surgeons know that if there is any raw tissue and the two tissues come in contact with each other, over a period of time, they would cause adhesions again. So the reason that we put the filler in is to A, support the scar which has now got raised, prevent it from adhering again to the basement membrane. These fillers would be high G' hyaluronic acid fillers, and because they would be thick fillers, they would prevent for about 6 months to a year this adhesion to occur. At that moment in time, the scar, which was V-shaped, would become a planar scar, and then it would be subject to carbon dioxide laser. We understand that the hyaluronic acid fillers would be a temporary mechanism, but the usage of the CO2 laser would cause the basement membrane, because it's a long fluence laser, would cause the basement membrane to actually produce collagen. And this newly produced new collagenesis would, over a period of time, replace the fillers, which was the hyaluronic acid, which had been put in right in the beginning. That is why this particular paper was very different from the way the scars were treated in chapter 4.
Okay, thank you for your answer. I will now give the floor back to the pro-rector.
Thank you. The opposition will be continued by Dr. Feijer, plastic surgeon at the Zuiderland Medical Hospital. Thank you.
Dear colleague, I would like to congratulate you on your extensive work. I have one question on chapter 3. Did you observe differences in psychosocial outcomes between surgical and non-surgical procedures? Because I can imagine if you do Botox, nobody really will see it. So does it really influence the way other people, your relationship with other people? So that's my first question.
Highly esteemed opponent, thank you so much for your question. We did not have enough data to be making a segregation between surgical and non-surgical procedures. And does Botox, to your question, does Botox make a visible difference? In people who have significant forehead lines, it would make a visible difference. And my spouse would probably notice that as well. And that could have an impact on the way that I ended up feeling. So my preliminary response is, I don't think it really matters whether we do treatments surgically or whether we do treatments non-surgically. I come from a surgical background, but I do see the benefits of using the newer technologies which are coming up, which may slowly and steadily, except in the extreme cases, make surgery obsolete over the next 2 decades or so. What matters is how we end up looking. What matters is how our spouses end up interacting with us. What matters is what we think of ourselves. And both surgical as well as non-surgical treatments could do the job of repositioning and causing neural pathways in our brain to become more confident, thereby leading to these changes, is what I believe.
Yeah, I think I totally agree. And there's also been a study on Botox, actually, that when you do it in your frown and you cannot really look angry anymore, that you feel a little bit better, so you feel less depressed. But anyways, my next question is about chapter 5. I thought your result for the acne scars are really beautiful. In our clinic, we have an erbium laser. We don't have it for very long, almost a year now, and we've seen some cases of PIH, and we don't have many patients with the darker skin type. So I was really interested in how you treated it. So I saw that you had 3 or 7 cases of PIH. That was not completely clear to me. And I was wondering, you described that you use hydroquinone before and after. So I was wondering, did you do it on everybody? That's the first part of my question, or did you do it on specific cases? And the other part is, I also saw you used hydrocortisone directly after the laser. So was that also to prevent PIH? So I would just like to, if you can elaborate a little bit more on that protocol.
Highly esteemed opponent, thank you for your question. Obviously, the darker the skin, the higher the chances of developing a post-inflammatory hyperpigmentation. I was speaking to someone else today morning, and I was speaking about how darker skinned people have different problems, in the sense we tend to get pigmentation even when you are sunbathing in the sun or going into the sea. That's the type of problem that we have. So the first thing to do when we started using carbon dioxide laser was to not use a full fluence laser. The objective was to use a fractionated laser. Because when we use a fractionated laser, you have a grid pattern. And when you have a grid pattern, there are areas of healthy skin in the middle of those grids. And those areas of healthy skin actually proliferate and help the healing of the tissue. So we don't do full face carbon dioxide laser without having a fractionated laser in place. We also use far lower fluences than we would use with white skin. So I have a practice where there are people traveling in from different parts of the world, and a significant Caucasian population comes into our practice. I'd be much happier using higher fluence lasers or higher powers with them than I would with the Indian population. So the darker the skin, the more careful we need to be. The hyperpigmentation that people developed was because not every patient listens to their doctors very seriously. We told everyone not to go out into the sun for about 7 days or so, which doesn't mean that they can't step out for a minute in the sun, but they can't be sunbathing or having a beach party at Goa immediately post the treatment. Now, one of the people that I know, who was a very close patient, actually ended up going in for a beach party and spending time outside in the sun, and Goa is one of the sunniest beaches on the planet. So obviously you'll develop hyperpigmentation. Now, using the hydrocortisone for some of them was left to clinical judgment. If patients had a history of developing hyperpigmentation before, or had a history of scars which were hyperpigmented, or had other types of problems like possibly a melasma which they had developed, then we were a little bit more cautious with them. Obviously, we didn't want to use hydrocortisone in everyone because that can have deleterious side effects, including making the scars themselves go a little bit more depressed because of the absorption of collagen. So from that perspective, it was a highly individualized, titrated, balanced approach, depending on what we saw. But what has happened is, over the last few years, because of these papers of ours which have come out, many Indian practitioners have lost their fear of the CO2 laser. And so there are many more clinics which are now using the carbon dioxide laser, and used in the right hands with the appropriate fluences, we do tend to see very good results, even in pigmented Indian skin.
And the part of my question about hydroquinone, did you use that also for the selected patient? Yeah. So the hydrocortisone did the same, and the hydroquinone is...
So the hydroquinone was used in selected patients, provided if they were developing any sort of pigmentation or they had developed pigmentation earlier in their lives. The interesting thing about India is 4% hydroquinone, which is legal in the United States, is not allowed in India. So for topical applications, we have only 2% hydroquinone, which is nearly not as strong enough as is required to remove hyperpigmentation. So PIH, the best thing to do is to try and avoid it, for the patient to have used sunscreens, for the patient to be respectful of protocols and not go sunbathing immediately post the procedure, and to take care, because once you develop PIH, then treating it is as difficult as it used to be earlier.
But in your cases, it resolved by itself, because that was described in your articles.
Yeah, absolutely.
You didn't have to treat it. It just resolved.
It resolved in these particular type of patients. And these particular type of patients also, whenever we take people up for a trial, they are also signing an informed consent, which is approved by the ethics committee. Whenever an ethics committee ends up giving an approval, usually it'll be a long, drawn, informed consent which tells them about the side effects, which means that you would generally not have patients who are taking liberties with the protocols that much. So in these particular type of patients, yes, we don't need to treat them. But at the same time, in general, in practice, when we are treating patients, there are patients who would require treatment, and we still need to be very careful.
Okay, thank you. If I still have time, I have one question about a proposition. So maybe one of your paronyms can read them. It's the proposition, let me see, the number 3 in the propositions not related to these theses, about the liquid facelift.
A layered liquid facelift, deep support plus superficial contouring delivers safer, more consistent results than blind single-plane filler injection.
Have the proposition.
So that was actually really interesting to me, because many plastic surgeons argue that dermal fillers not truly lift the face. So can you clarify that concept? That's one. And from an anatomical and biomechanical perspective, how does deep plane filler placement interact with the facial retaining ligaments that stretch? So how is there evidence that this interaction results in sustained tissue elevation rather than temporarily volumizing the face?
Highly esteemed opponent, thank you for your question. I will first lay out the context in which this proposition has been framed. And when we talk about a liquid facelift, we've actually trademarked this particular name, and we speak about it in a lot of our papers, upcoming manuscripts. We call it the aesthetic lift. And the aesthetic lift actually talks about how we first use a machine which could be something which has a high fluence like the Altera, like a high-intensity focused ultrasound. The objective of using that machine first is because Indian faces, we also, the background and the context is in 2019, we published a paper which was a photographic study on how Asian Indian faces age. What we discovered was that Asian Indian faces tend to age very differently from Caucasian faces. We know that, but we actually put it into mathematical algorithms how these faces age. And what we found is that essentially the skull in Indians is much smaller than the Caucasian skull. And because the skull in Indians is smaller, and a lot of us put on weight as we grow older, we love food, and so as a result of which we grow fatter as we grow older, there's a lot more tissue which is hanging by and a lot of definition in the lower face and in the neck. So essentially, what we discovered was majority of the faces are oval when they are young. But as they become older, they tend to become more and more squarish in nature. So the first thing in a liquid facelift protocol is that we want to reduce tissue, not add tissue. And that's why using the Altera is a great way of producing collagen, developing a good matrix, tightening the retaining ligaments that you speak about, and ensuring that the contour becomes better over a period of time. Post that, we use in the liquid facelift, in the protocols we describe, threads. And cork threads are a good way of lifting. The idea is we should always try, for a heavy face like an Asian Indian face, we should always try to lift first and fill later. because you don't want to be filling too much in a face which is anyways becoming broader as age is going on. So first the Ulthera, followed by the threads, followed by the fillers, and followed by the Botox, which essentially means that you're using the fillers, but you're using the fillers in two different planes. So the fillers that would be used in the under eye area, because we also have darker skin, which means we are more susceptible to the Tyndall effect, because the fillers would actually show total internal reflection and be seen below the skin. So therefore, use low G' fillers here. But when you're using the same fillers over the zygomatic arch, or when you're using it over the zygomatic body, then use deeper plane fillers, which are in the just anterior to the retaining ligaments, in order to ensure that we have an elevating effect. The elevating effect is not caused only by the fillers. It's caused by the entire protocol of a liquid facelift, which in turn drives this.
So I think then the term liquid facelift might not be correct, because I think you should call it multimodality non-invasive facelift, or because then it makes it more clear what you do. But thank you for your answer.
Thank you so much.
Thank you. The opposition will be continued by Dr. Kelleners, Associate Professor of Dermatology at this university.
Thank you very much. Dear candidate, at first I would like to congratulate you with this beautiful dissertation, and also beautiful design book. And I would like to congratulate your team. Well, first I would like to focus on the fact that you describe a problem of the increase in cosmetic procedures in India. You've seen them in India, but we notice this, I think, worldwide. We dermatologists, we also face with a growing problem, which is skin cancer. And we like to collaborate with our plastic surgeons on this, because we can't handle all these tumors alone. So I need them for more things than cosmetic procedures. We as dermatologists, we don't only treat patients with skin cancer, but we also invest a lot of time in skin cancer prevention. And now I was wondering, you described that the problem of undergoing many cosmetic procedures is particularly prevalent among women with low self-esteem and heavy TV consumption. Have you already thought about preventive measurements on this fact? So you don't have to treat them anymore, but they work on their self-esteem and don't need a cosmetic procedure. So do you think there's also a role for plastic surgeons for a preventive matter?
Highly esteemed opponent, thank you so much for your question. Prevention is better than cure. A stitch in time saves 9. And we've all been taught this right from the beginning. The biggest organ in the body is actually the skin, and dermatologists treat the skin. For plastic surgeons, dermatologists are a boon, because they make all our results look far better because of the way the skin ends up looking right at the end of it. So from that perspective, prevention is very important. I come from a head and neck surgery training background, and I used to be very proud of the free fibular flaps which I used to perform. The fact of the matter is that every problem is a problem. Whether that's a jaw cancer which needs to be treated with a free fibular flap, or a lady who's got melasma which is impacting her self-confidence completely after she's born children. So prevention should be a part for every medical specialty. It should not be a part only for dermatologists. Using of the proper skin creams, using of whatever's required to be done to prevent other problems from coming in is very important. We need to, in Indians, we do not have that much skin cancer. But at the same time, if we were to use sunscreens and use preventative methods, then there would be lesser requirement of other treatments for skin pigmentation, etc. So completely, yes, agree with you, and thank you for bringing that to our notice.
But also the fact that you mentioned there are now more male patients coming to your clinics because they need they think they need a cosmetic procedure. Is probably social media, you're saying. Wouldn't it be a way to prevent them coming by just showing that you can be happy, not looking idly, with an idly face?
Everyone has a right to decide what makes them happy. And I think in democracies especially, we need to be giving people the right to self-choice. I believe my job as a cosmetic surgeon is not to convince people to undergo treatments. But at the same time, if they feel that if someone's bald and they feel that having hair would make them a better version for themselves, then it's not my job as a doctor to judge them. I think in such sense, it would be better to give them the entire facet of treatment. Did I misunderstand your question by any chance?
No.
So I feel that it's important to be providing what people come in to do. Our job, in my opinion, is to provide a concise list of what a treatment can achieve, what it cannot achieve, and allow a patient to take the informed position whether they would like to undergo the treatment and give us consent for the same.
Yeah. Okay, thank you. Then I would like to go to chapter 5, where you investigated the combination of the substituent individuals and the fractional carbon dioxide later. For the acne, my colleague already mentioned you did a cohort study and have no control group. Can you state that this is really a better treatment, or will you be doing another study to really prove that this is the better one? And how would that study look like?
Highly esteemed opponent, thank you for your question. We've done each of these treatments separately. So in an acne scar, we've done CO2 laser and not nearly seen the same results that we saw in this paper. We've done just the subcision without putting the fillers in and not necessarily seen the same amount of treatment. So combining these treatments, in my opinion, gave us far better results. But the way to actually evaluate it, which was also brought by the other esteemed opponents, would be to have two groups, compare them, and then look at one versus the other. The challenge, though, is when we try to take age, gender, and disease-matched controls, it's difficult to have people having exactly the same scars and having exactly the same problems. So therefore, it does become a problem in some of these comparative studies to try and see what happens.
Yeah. So you're saying you already done a study also in fractional laser alone? As a single treatment?
We've done fractional CO2 laser. It's a data on file. There was no way to get it published because that has already been proven that there are advantages of using fractional CO2 in acne scars, but that didn't necessarily produce the same results after using this protocol. So we've been very happy with this protocol, and we felt empowered enough to be offering it to all our patients post the study coming in. But obviously, if we had to compare apples and apples, it would be good to have a control group.
Yeah. And you did, short question, you did include patients of several age groups. I miss, what you're saying, they probably have different results. Subgroup analysis for age or, type of lesions.
We didn't see any difference.
Maybe also a short answer.
Yeah.
We didn't see any difference. And it was impossible with the data available to reach any conclusion on the subgroup analysis.
Okay, thank you. I will give the floor back.
Thank you. The opposition will be continued by Professor Scholz, Professor of Plastic Surgery at the Free University in Brussels. Thank you for coming to Maastricht.
Thank you, dear candidate. I will speed it up a little bit to leave some time for Professor Weber. Congratulations on your work and also for your supervising team. It was interesting to read about your experiences and developments in India. First of all, I would like to talk about Chapter 2. You already mentioned that there's a trend towards non-surgical treatments in aesthetic surgery. And in the Netherlands and Belgium, not only plastic surgeons and facial plastic surgeons, but also other medical specialists perform these treatments. How is it in India? Do you also have people who are not trained as doctors who perform these treatments?
That's a highly esteemed opponent. Thank you so much for your question. That's a problem no matter where in the world we are. So, for instance, one of the major problems that I trained in the US, and one of the major problems in the US is that in New York City, Botox and fillers could be performed by a nurse. This is true in India as well. The challenge is not that a nurse would do the same, but there are many dental professionals, for instance, who are getting into things like this. There are many Ayurvedic professionals who are getting into it. So there are multiple other things which are other types of trainings which are not recognized by modern medicine as having the ability to do these procedures who are getting into these procedures more frequently.
Thank you. And is there any legislation or regulation by the Indian government already, or?
The challenge is, like in other parts of the world, health is a state subject. There are 30 different states. Each of the states is as different as Belgium is from Netherlands. And to get all the states to agree on legislation becomes very difficult. And even though there is legislation, in a big country, sometimes enforcement of that legislation may be a problem as well.
Mm-hmm. And so how do you see a lot of complications from non-surgical treatment by non-medical trained?
We see a lot of skin burns which come in from people who have not been trained. They say that the less trained you are, the more confident you are. And the lesser knowledge that you have, the more confidence you have. And so some of these salon and parlor ladies actually use carbon dioxide lasers nowadays, and which is really scary because I still tend to get scared with a carbon dioxide laser in my hand. And that's why we see a lot of skin burns and PIH cases which come up all the time.
Okay, thank you. So I will proceed with another subject. Can one of your paranyms read the second proposition regarding rhinoplasty, please?
Patients undergoing cosmetic, oh sorry, it's the other one, right?
On rhinoplasty.
Not related, yeah. Rhinoplasty in Indian patients requires technique modification, open structural augmentation with autologous cartilage, provides superior aesthetic balance in broad osteocartilaginous nasal frameworks, typical of South Asian morphology.
So on the one hand, you describe that there's a trend toward non-surgical aesthetic procedures, so I can assume some people, they suggest to do like non-surgical augmentation of the dorsum of the nose. And on the other hand, you say people in India are still somewhat afraid of doing surgical treatment. That's a difference with the Western world. And in your proposition, you describe that the ideal approach to the South Asian nose is the open surgical approach. Do you think that that's the ideal approach, or do you think there's also a place for preservation techniques? What's your algorithm for the Indian nose?
Highly esteemed opponent, thank you so much for your question. I'll lay the context down for this. Obviously, if it's a small nasal hump, then it's possible to just do some fillers on the dorsum and get that treated. But at the same time, if it is major work, which basically means it's a crooked nose, which is also functionally leading to problems, then there would be no other option than actually straightening the septum out and making sure that the nose is operated. So in that context, especially with our sort of anatomy, our unique anatomy is that we don't have a very strong cartilaginous structure. And when you don't have a very strong cartilaginous structure, you typically need a columella strut graft, which will have a conchal cartilage, which will have to be used, or you would need some other tip support mechanisms, perhaps even a rib cartilage in place. In each of those places, it possibly becomes harder to use preservation techniques, and therefore using open rhinoplasty to structure and augment the osteocartilaginous framework would possibly be served better by an open rhinoplasty technique in those cases.
Okay, so the septum is not the first place to go to.
It is the first place to go to for all of us as surgeons, but the septum in many of us, especially in the deviated noses, may be of a very poor quality. And when it's of a very poor quality, even if you've removed and left just the 15 millimeters in the L strut, which is present, the remaining septum may sometimes need double breasting to provide enough support at the columella strut graft. What that means is there might not be nearly enough cartilage which comes out of the septum, and even though that's the best, it's hyaline cartilage, it may not serve its purpose completely.
Okay, thank you. I'll satisfied with your answers. I give the word back to the prorector.
Thank you. The opposition will be continued by Professor Webers, Professor of Ophthalmology at this university.
Okay, Mr. Candidate, I first would also like to congratulate you and the supervising team, although you still have to answer my questions in 4 minutes. These are mainly about chapters 6 to 11. And first you have to clarify something to me. In chapter 7, you used the QR678 intradermally, And in chapter 9, you use it comparing to a derma roller technique. But if you look at page 83, there is a picture of a patient. And page 113, there is the same picture. So was that patient treated by intradermal injections or derma rollers? And why is the same patient in 2 of your publications?
Yeah. Thank you so much, highly esteemed opponent. Thank you so much for your question. In page 83, when this person has been spoken about, it speaks about intradermal administration, which was a phase 4 open label trial, which was done in multiple centers. Now, this particular person was treated intradermally. Now, when what we also did is we compared in the second, which is the intradermal paper is chapter 9. When we looked at chapter 9, by that time, COVID had broken out. And once COVID broke out, it was not possible to have the patients come back and get treated intradermally at the clinics. Which is why we decided to try self-administering the QR678 at the patient's homes with an intradermal technique. So chapter number 9 actually has 2 groups. It has one intradermal group and one injection group. So this is the injection group which has been used in chapter number 9 as well.
You have to reread it because group B was the derma roller group.
But that is
okay. Sorry.
Error,
okay.
But...
Well, what amazes me is that you seem to have very good results in different types of alopecia: androgenetic, PCOS-related, areata. Is it a kind of a panacea? Did you invent something that works for everyone?
Not at all. Highly esteemed opponent, thank you for your question. I'd actually like to take the context. Many years ago, about 15 years ago, we were working on nanomolecule carboplatin. And serendipitously, we discovered this route of treating hair growth. I will not get into the details because I don't have enough time with me. But essentially, we got a US patent. Getting a patent from the United States Patent and Trademark Office is extremely difficult. The reason that this particular formulation got the United States patent was because it converts the telogen and the catagen phase hair into anagen phase hair, which essentially means that dead and dying hair are converted into living hair. Does that mean that it will work in every type of hair loss? No, it does not. It does not work in cicatricial alopecia. So anything which has caused the hair follicles to get completely damaged, for instance, psoriatic hair loss, etc., it will not work in those cases. But if the hair follicles are not completely destroyed by a scarring process, which means it's non-cicatricial alopecia, this would work in converting the cell cycle. And because this is the first time in human history that a cell cycle change was attempted and successfully done, is why we had the US patent granted to this. So it can work in biochemically, whether we lose hair because of genetic reasons or whether we lose hair because of immunological reasons. Ultimately, it's a conversion of the active growing stage of hair, which is the anagen phase of hair, into a catagen and telogen phase. And therefore, at that biochemical level, this would work well.
Okay. It might have helped you if Trump would have been bold, of course, to get your patent in the US. However, how does blinding work in such studies? Who is blinded? For which treatment? How does it work?
So the blinding would work in this manner. A study could be single-blinded or it could be double-blinded. If it is single-blinded, then the patient would not know exactly what is being administered. I mean, in the sense whether it's a...
Well, he would know whether he uses a dermarol or gets injections, I think.
Yes, but at the same time, what we could do is we could actually look at patients who've been randomly allocated to certain parts, and you're absolutely right. They wouldn't be blinded in the true sense of the word, but they would be randomly allocated and thereby able to use the treatment through either a derma roller versus an injection technique and come to the clinic.
One short question. A longer question also. Okay. All 6 papers were published in the same journal. Was there a particular reason? So I could imagine, I'm putting also a possible answer in, but if you are bold because of a treatment for another disease, why didn't you choose, for instance, a oncological journal or a broader journal? Why specifically the aesthetics? Since it seems very good therapy.
Highly esteemed opponent, thank you for your question. There are 16 papers which have been published on the QR678 Neo. Only a couple of these are part of this particular thesis and particular work. These papers have been as diverse as plastic and reconstructive surgery journals, and they've been published all over the world. There are a few more papers which are coming out and which are in new journals as well. So the thing is, what tends to happen is sometimes when we publish a particular paper,
You may finalize your answer, but very short.
When we work on certain things and something has been sent to a particular journal and has got published, then they know about this particular thing which has been done, so it gets easier to publish other articles because they may perhaps be aware of it. Plus, there might be a cross-citation from the same journal, which helps the case sometimes.
Thank you very much.
Okay, thank you. Debraj Shome, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
They have to only know the parts you let them know.
Debraj Shome, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualification, the committee has decided to grant you the degree of doctor. Professor van der Hulst is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Debraj Shome, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by Rector, the Secretary and the other members of the committee and affixed by the official seal of the university. Dear Dr. Shome, it's a great honor for me to be the first to congratulate you on achieving this doctor degree in the Netherlands. Although I saw in your CV that you're already professor doctor, but that's different, I think, in every country. I'm also a little bit disappointed because your research is about 30 years too late. As you told me yesterday, I'm a lost case. Your medication, your QR 6, 7, 8 medication is a little bit too late, but I'm happy that you were one of the people seeing 6, 7 as one of the first, so I'm happy with that. We came in contact due to my colleague, Professor Greve, who's a bariatric surgeon, and he had contact with a PhD student in India, and this PhD student knew you very good, and he asked me if I could do your supervision. So we started mailing, and it was about 2019, just before COVID. And since then, we just mailed. Actually, yesterday was the first time we met live. I decided to go for it because in that same period, we had a kind of opposition like this with 2 Indian ophthalmic surgeons. And after having dinner, and also Professor Webers was there, I talked with the supervisors and also with his Indian PhD students, and they were very enthusiastic. And also the supervisors told me that if you just send a mail to one of you, you just respond within an hour, even if it's in the middle of the night. We're not always used to that. So that was indeed the case. I also experienced that with you. Our professional past crossed again when I was invited to collaborate with you and to write a chapter in the sequel of your book, Dear Doctor. You had written a book, and it became a bestseller on patient-doctor relationships. And you asked me, do you want to contribute to another book, which is just being published, Doctors Are Not Murderers. I knew that, but some people maybe not. So we wrote a book together. I wrote a chapter in that book. And since then, we came more and more in contact. And I experienced you as a person who really is able to translate complex ideas into clear sights. And also, you're very much driven by curiosity. you're not only an outstanding surgeon and scientist, but you're also an entrepreneur. You have varied private clinics. You're very active on social media, but you also add value by giving back to the community, and that's something I very appreciate. So we have worked over the few years in several studies which have been published, and you always were engaged and critical when necessary. So not only as a clinician, but you're also a tutor and a very inspiring person. We not always agree on every subject, but I respect very much the way you can connect people and inspire people. You're not only recognized in your own country as a leader in facial plastic surgery, but also in countries far from your own country. And as I said, the most I admire in you is that you genuinely want to invest in the growth of others. So, concluding, I thank you for your collaboration, your partnership. We discussed that we can maybe go in the future, go on with other PhD students. And the advantage now will be that you will be there, so there will be a more intensive collaboration, and I hope this will be a success. So I would like to end with, again, congratulations to you and your family.
Dear Dr. Shome, I also want to congratulate you with this achievement, and I do that also on behalf of the University Committee, of a community of Maastricht University. I think you did an excellent job today by also promoting India and your work. Regarding alopecia, I know that some JAK2 inhibitors are also used, but you have your own cocktail, and hopefully that will be a success in the future. I now want to give the floor to Professor van der Leij for a short word.
Thank you very much. Dear Dr. Debraj Shome, congratulations with your well-deserved promotion. Although your QR678 also came too late for me, I really can't be bothered, because men being bold will be the norm, the ideal norm in 2050. So it will be not a problem anymore. Nevertheless, I wish you a lot of success in the future with your clinical work and research, and the way you act should be an example for many others. Thank you very much.
Thank you, and this brings me to the end of this academic ceremony. I close the ceremony, and we stay a little bit longer here for a few pictures, and also with our guest on the screen behind us. And there we close this academic ceremony.